and Dr. Sabyasachi Sengupta, the optimist and the pessimist, to occupy their positions.
Also, we would like to invite Dr. Abhishek Kothari to occupy the referee's position.
So here I am to present that, my slides please. Yeah, so I am the optimist, and I say that the presence of hyperreflective spots change the management of DME. Before I start my presentation, I need to acknowledge my fellow Dr. Aarti for collecting all these images and the literature search that she did for me. So here is my first case. This is a patient with diabetic macular edema who has a lot of hyperreflective spots at baseline and a subfoveal detachment. And after receiving an injection of Avastin, there is some response to the edema, some amount of decrease in the SRF, but the spongy edema doesn't seem to have responded much. After a second injection, the patient seems to have a rebound increase in the edema in the eye. The HRF seem to have reduced a bit with these two injections. Second case, this is a patient with a massive diabetic macular edema, a lot of subretinal fluid and numerous HRS. And he received an injection of Avastin, and you can see there is some reduction in the edema. This patient went on to receive 6 injections of Avastin at regular intervals. The edema is reducing with each subsequent injection, and we can also see that these HRS here seem to be aggregating together. Some literature suggests that these HRS may be precursors of hard exudates, which may over time aggregate to form hard exudates, which are visible on fundus examination. As more and more injections are given, the subretinal fluid is resolving, but the spongy edema seems to be persisting, and the HRS seem to be aggregating together. So this is the third patient. He has a subfoveal hard exudate plaque with a lot of HRS, edema and subfoveal fluid. Now this patient received IVTA at baseline, and there was prompt resolution of edema, which was then maintained. Now coming to the fourth case, now this is an even more interesting case. If you look at the right eye of this particular patient, he has multiple HRS at baseline with a lot of edema. He received 2 injections of Avastin, to which he did not respond much. Following this, he received an injection of IVTA, for which there was a better response than Avastin, but it recurred after 3 months quite badly, a lot of massive recurrence. At this point, this patient received an injection of Ozurdex, and it responded to the injection of Ozurdex. Now if you look at the same patient and his left eye, which had much lesser HRS at baseline, the left eye received 2 injections of Avastin and the edema completely resolved, which goes in the favor that HRS at baseline indicate a poorer response to treatment, a poor response to anti-VEGF, and could be an indicator for a faster switch over to a steroid therapy. In steroid therapy, I think as Dr. Jatinder already pointed out, the response to Ozurdex seems to be better than IVTA. Also, there is some evidence in literature, and also as we saw in the case 2, wherein these HRS seem to aggregate together and may lead to the formation of hard exudates eventually. I rest my case. Sengupta, over to you.
Can I have my slides, please? A very good morning to everyone, and thank you to Unni and Manoj and Jay for having me here and giving me this opportunity to discuss something which I actually learned during the last RIC meeting, that was hyperreflective spots. And ever since the last year, I have kept my eyes open to this entity, in my patients. So what we already know is that hyperreflective spots most likely indicate microglial cells, and they are markers of inflammation. So this is an inflammatory phenotype of diabetic macular edema, and these hard hyperreflective spots are slightly different from hard exudates, micro hard exudates, and many other hyperreflective substances which are in the inner and outer retina. They are not exactly seen on color fundus photography, and vision wise, those with hyperreflective spots may have lower vision, and response to anti-VEGFs may be poor. So how does this impact management? So I think the two key, I think this can go in many different directions, but I think the two important sort of impactful questions are, given that this is an inflammatory phenotype, would first choice of pharmacological agent in the presence of HRS be an anti-VEGF or a steroid? And like already has been said before, would switching earlier to Ozurdex or an intravitreal steroid be more prudent in cases of non-response? So I'll show you some scenarios where there are HRS with DME which responded to anti-VEGF very well, then HRS with DME which did not respond to anti-VEGFs. HRS have also been described without diabetic macular edema and also without even diabetic retinopathy at all. There are other biomarkers, it's not just the HRS, I'll show you some examples of that. And of course, there are some insights into literature and what's missing, which I'll probably convey to you, and there'll be some take-home messages. So this is the first case which has a lot of HRS. As you can see, hyperreflective spots, there is a serious macular detachment. At 1 month post-injection, there is significant reduction, and at 2 months post-Avastin, there is complete resolution despite presence of hyperreflective spots. This is another example. Again, there is focal traction, but there is significant reduction, gradual reduction, and good response to anti-VEGFs. Here are some examples from literature where you will see, there is cystoid macular edema and hyperreflective spots, but they are, resolving very well from 624 to 6/6 after Avastin. This is another case where there is significant edema. You can see a lot of hyperreflective spots. After 3 injections, the BCVA has returned to 6/12. So there is good response to Avastin or anti-VEGF despite hyperreflective spots, and these have been treated, like any of you would. I don't think any of you would have treated this differently. And so there is no difference in line of management despite the presence of hyperreflective spots. Now here is a case where there is a lot of edema at baseline. 1 month post Lucentis, there's not much resolution. 2 months after Lucentis, there's not much resolution. And so, you think about switching, you switch to Ozurdex, there is some amount of resolution, but 2 months after Ozurdex, there is again, recalcitrant sort of edema. So here there is poor response to Avastin, and also there is inadequate response to Ozurdex, and yet the line of management did not change despite the presence of hyperreflective spots. Like I said, hyperreflective spots have been described even without diabetic macular edema. This is a paper by Professor Bandello from Italy, who has shown these spots even without any macular edema. Again, some more examples of that. And hyperreflective spots have been shown without diabetic macular edema and any diabetic retinopathy at all. So that really makes you think, when these are not present in only exclusively in eyes diabetic macular edema, is it really, what is the role of this entity in the pathogenesis, response, treatment outcomes, etc. And of course, there are many other biomarkers. This is a very good paper which talks about different biomarkers in response to treatment with the DEX implant. And if you look at the things marked in red, what it said is that the presence of subretinal fluid, the absence of hyperreflective foci in the integrity of the ISOS layer were all predictive of better visual outcomes. This is very hot off the press, which is published right the month before. And this talks about dexamethasone for unresponsive diabetic macular edema and the OCT biomarkers. And what it essentially tells you that hyperreflective spots with neurosensory detachment has a better response. Hyperreflective spots has poor response, again, in this Japanese cohort, where if you look at just the bottom line, it says hyperreflective foci in foveal cystoid spaces at baseline predict poorer short-term responses to ranibizumab injections for DME. So the role of hyperreflective spots in response to treatment is clearly controversial. Some studies are saying if they are present, it responds better, and then some studies are saying if it's present, it doesn't respond so well. So when will I alter my practice pattern is when I get an answer to this question, that a study that compares Ozurdex versus ranibizumab head-to-head in eyes with hyperreflective spots reliably. This is one study in 2017. Again, if you see, it shows the number of hyperreflective spots in each of these groups, and there is not much difference there. So the effects of these are equal. And there is another, actually a randomized controlled trial on this, which compares intravitreal dex and aflibercept in patients with hyperreflective spots. And again, what it really concludes is that aflibercept slightly better than dex, and not the other way around that we might have thought. And this still won't make dex the first choice even with inflammatory phenotype like this. And I would really eagerly be waiting for a study which actually shows us something like this, where you compare eyes with DME and hyperreflective spots and DME without hyperreflective spots, and then compare across the chronicity of DME, HB, A1C, neurosensory detachment, ISOS, integrity, etc. And if you look at a PubMed search of this entity, there are about 37 studies, and actually original articles are only about 10, so not much work since 2009. So my take on this is that it's not easy to identify, especially in OCT machines, other than the spectralis. There is variability in how HRS has been defined in studies, adding to the confusion. Enough conflicting evidence in its role. And so I think the first choice of DME still remains anti-VEGF and not Ozurdex, irrespective of the number and location of the hyperrefractive spots. Likelihood of switching over to steroids maybe earlier, still not enough evidence. And we still need more literature with larger numbers adjusting for other confounders and pinpoint hyperrefractive spots as a major influencing OCT biomarker to change my practice patterns. I'm always an optimist, but with a balanced view, and I rest my case. Thank you.
I think Abhishek has a difficult task of balancing the two. He's usually
So as far as the HRS is concerned, the origin is, there's no direct histopathological correlation along with the OCT image as to what it is. And the postulation rather it comes from different sources. It could be activated microglia, it could be lipid leakage. So we really don't know whether it's only a biomarker for inflammation or a biomarker for increased leakage. However, in light of all these studies, like you said, it's not an indication for shifting to steroid, but I would definitely tend to lean on the side of shifting, or maybe have a earlier treatment modification if I see a lot of HRS. And I think in view of that, possibly I would agree with Manavi that if I have a lot of HRS, I would tend to be quicker in my shift to a steroid as compared to continuing with the same anti-VEGF therapy for quite a long time. So I think that's what my take was, and I'd like the panel also to opine on that.
We did do a study since last year. Sriram, can you make a small comment on what we have done on hyperreflective dots in DME? We can hear you. Go ahead.
Basically, we have evaluated all the cases who responded to anti-VEGF and who responded to steroid. We had 21 patients who responded after addition of steroid, and out of the 21 cases, 10 patients out of them had hyperreflective dots. And basically, even in the literature which you presented, sir, that there is a poor response to ranibizumab. They didn't, in the other paper, they responded to Ozurdex. So basically, it is a marker of inflammation with good response. But one more thing is, it is not just the inflammation, even the VEGF load which plays a role. So there should be a balance between both an anti-VEGF and steroid implant. And yes, in all the cases which respond to Ozurdex, we had followed up for 6 months post-injection, and we noticed that it reduces the need of anti-VEGF by a ratio of 1:4. The group which did not have hyperreflective dots still went on to require anti-VEGFs at least 4 times more than the group which received Ozurdex.
Thanks, Sriram. Are there any other comments?
I think there is a consensus that HRF do have, there is an inflammation which is present. But I think what we forget is that probably DEX as well as anti-VEGF that we give, both have an anti-inflammatory effect as well. So which is why anti-VEGF may also help in patients who have HRF. But the proportion of anti-inflammatory effect of DEX would always be more than what is there for an anti-VEGF.
We have changed our practice pattern, particularly not only in DME, HRS has been improved. In AMD and PCV, if you do find HRF, I add steroid to it and find that the response is better. So I think we are running behind time.
Can I ask one doubt?
Your mic is not working. Yeah, now it's better.
Can we assume that all this HRS is due to just inflammation alone? Can it not occur in other, like you see it in AMD, can it be due to a neurodegenerative?
No, I agree. Like all of them, we're dumping it as saying HRS. HRS is not, it's just a single entity. Because some of the images which Dr. Sabyasachi showed, some of them are hard exudates. Even hard exudates can look like hyperreflective dots underneath. So we need to quantify as to what is what, and the size wise we need to quantify or qualify, and then subsequently add up steroids if it's not responding. Not every HRS has to be treated with steroids.
And I think HRF in different diseases may mean different things. Yes. So that also probably we have to take into consideration. In some cases it may be the early beginning of the disease, whereas in other cases it may reflect chronicity of the disease. So that has to be kept in mind. Probably in AMD, the beginning, as he mentioned, Dr. Jatinder mentioned that it begins in the outer retina, while in the vascular diseases you may have it closer to the inner retina. So you have to take the whole picture together.
And can we differentiate that on the image? when in terms of reflectivity, because there's some people have described that some of these HRFs are as reflective as the nerve fiber layer, or others have described it as reflective as the retinal pigment epithelium. So can that be used as a guide to differentiate what kind of HRF are we dealing with?
I think one is particular that if they are causing shadowing, it is then hard exudate. If they are not causing shadowing, then you can still consider them an HRF. Anything on that, Dr.?
Yes, and in addition, we can quantify based on the vitreous reflectivity, can alter the reflectivity. But this is something which is not standard because machine to machine it varies. You can come to some conclusion based on the reflectivity and come to that. I think Dr. Adnan wants to say something.
Yeah,
about
so
that.
at the moment I'm not convinced I can say what it is just on reflectivity. Secondly, we don't have really good histopath correlates, and that, as was mentioned, may be disease specific, and even within a disease, hyperreflective dots could represent different things. We now have a multispectral simultaneous OCT. We're trying to see if we can differentiate them, but then what's the gold standard even if we can separate different entities? So I think there's a lot of work still to be done to really understand this.
I think the last comment by Dr. Jati, because we are running behind time. Thank you, Dr. Sabyasachi. Thank you, Dr. Manavi.